All right, welcome future master engineers of the human body. Today we're going to fire up the boilers and decode the most intricate, beautiful, and sometimes terrifying machine of all, the human heart.
You see, your patient isn't just flesh and blood. You've got to think of them as a complex system of pressures, flows, and electrical impulses, a true symphony of cogs and currents, all working in perfect, delicate harmony.
So when the alarms start blaring, when this engine starts to sputter and cough, you are the frontline mechanic. So let's make sure you're ready to get your hands dirty and fix it.
So here's our game plan. We'll start in the engine room to understand the basic mechanics. Then we'll get into the electrical schematics, the ECG. After that, we'll cover common malfunctions, then move to the really critical failures. We'll review our pharmacological toolkit, and then we'll finish up with some questions to get you certified as a master mechanic.
Okay, first things first. You can't fix a machine if you don't know how it's built, right? So let's pop the hood and take a look at the blueprints.
Let's follow the fuel, which of course is the blood. So the old used-up, deoxygenated stuff comes into the right side through the vena cava. It goes through the tricuspid valve, then the pulmonic valve, and off to the lungs to get recharged with oxygen. Then that fresh, high-octane blood comes zipping back to the left side, goes through the mitral and aortic valves, and then bam, it's pumped out to the whole body. You need to know this path like the back of your hand.
All right, let's talk about the key components you absolutely have to know. First, you've got the SA node, the primary ignition capacitor. It fires 60 to 100 times a minute. Then, the AV node acts like an ignition delay relay. This pause is crucial. It lets the chambers fill up before they squeeze. And then, you have the main boiler, the mighty left ventricle. Look at it. It's 2 to 3 times thicker than the right ventricle for a reason. It's doing all the heavy lifting, pumping blood to the entire system. Put it all together, and you get your cardiac output.
Okay. Now for what might be the single most critical skill you'll ever learn, reading the machine's diagnostic report, the ECG. This right here is what separates the apprentices from the masters.
Look at that. It just seems like a bunch of squiggles on a screen, doesn't it? But those simple little lines, they tell the entire epic story of a single heartbeat. It's the machine's secret language, and we are about to crack the code.
So let's break it down. That first little bump, that's your P wave. Think of it as the spark firing, the atria contracting, atrial depolarization. Then you get that huge spike, that's the QRS complex. This is the main event. The main pistons are firing, the ventricles contract, and blood goes flying. And that last little bump, that's the T wave. That's just the whole system resetting for the next go-around. You need to know these cold.
All right, so even the most well-oiled machine can have timing issues. It can run too slow or way too fast. Let's dig into the common malfunctions you're going to see all the time, both on the floor and on your exams.
Okay, pay attention because this is a huge exam alert. You're looking at the monitor and you see this. The rhythm's regular, P waves look good, QRS is nice and tight, but the rate, it's chugging along at under 60. The engine is just running way too slow. This is your classic sinus bradycardia.
Now here is the absolute key. It's not just about saying, oh, it's slow. The real question, the million-dollar question that determines everything you do next is this. Is your patient stable or unstable? Are they dizzy? Are they passing out? Is their blood pressure in the tank? That single question is everything.
So, if they're unstable, the algorithm is crystal clear. Your first move is atropine. Think of it as a chemical kickstart for the engine. But, and listen to me here, you always have those pacer pads ready to go as your backup plan. Because if atropine doesn't work, you don't hesitate, you pace.
Okay, we've done slow. Now let's flip the script. The engine is redlining, racing at over 100 beats per minute. Everything looks normal, it's just really, really fast. The crucial thing here isn't just to slow it down, it's to figure out why it's racing.
Now, a lot of the time, this can be totally benign. You know, maybe they're scared or they just had 3 cups of coffee. But, and this is a big but, you have to think about the context. If you see this in a patient who just had a heart attack, that is a massive flashing red light. It means that damaged heart is working way too hard, and it could be a sign that heart failure is right around the corner.
And now, we enter the red zone. These aren't just malfunctions anymore. These are critical, system-wide failures. They require immediate, decisive action. This is where you earn your reputation as a master mechanic.
Okay, take a deep breath. When you see this pattern on the screen, These wide, bizarre, ugly-looking QRS complexes firing off at a ridiculous rate? Your own heart rate better speed up a little, because this right here, this is ventricular tachycardia. It's a precursor to full-blown cardiac arrest. The ventricles have gone completely rogue.
And this is maybe one of the most important decision trees in all of cardiology. For VTAC, it all comes down to one simple question. Do they have a pulse? If they have a pulse and they're stable, okay, you have a minute. You can try drugs like amiodarone. But if they don't have a pulse, you don't think, you don't wait. You start CPR and you shock them immediately.
Any master engineer has to know their toolkit inside and out, right? Well, our tools are pharmacological and they're incredibly powerful, but every single one of them leaves its own unique signature on the ECG. Let's take a look.
Okay, lean in for this one, because this table is pure gold for your exams. Let's walk through it. First up, beta blockers, like metoprolol. Think of these as the brakes. They slow the heart rate, and you'll see that as a longer PR interval. Now check out the sodium channel blockers, like flecainide. These actually slow down conduction through the ventricles, which can make the QRS complex wider. And finally, look at a real workhorse you'll use all the time, amiodarone. It's a potassium channel blocker, and it messes with the whole cycle, prolonging both the PR and the QT intervals. You have to know these signatures.
So, you've studied the machine, you've studied the toolkit, now it's time for the final certification. These are the kinds of questions that separate the rookies from the real master mechanics.
Okay, look at this side by side. On the left, what do you see? You've got a normal beat, another normal beat, and then silence. Just a flat line where a whole PQRS-T complex should be. That's called sinus arrest. It means the main ignition, the SA node, just didn't fire. This is a problem with impulse formation, and trust me, that distinction is a classic exam question. All right, here's a classic scenario for you. A patient has a pacemaker. You can literally see the little spike from the pacer firing on the ECG strip, but nothing happens after it. No QRS. The spark is there, but the engine just isn't turning over. What's going on?
The answer? It's called failure to capture. And this is so important because it shows your job isn't just to spot the problem on the monitor. It's to know the likely causes, like maybe the wire moved or the energy setting is too low, and to troubleshoot it. You're not just an observer, you're a troubleshooter.
So let's end on this final thought, because fixing the crisis, getting the patient stable, that's not the end of the story. It's really just the beginning, isn't it? What comes next is the constant vigilance, the patient education, and the deep, profound understanding that you are now the guardian of this incredible, intricate steampunk machine. And that is the art and the science of what you do.